to Wellards' 4th annual conference. We do have a fire alarm test in a moment, so I'm just filling in. You do not have to vacate the room, having just sat comfortably in a nice warm auditorium. And we'll wait for the fire alarm test to finish before we start the main event of the day. Those of you who are in early, latecomers, you're late. I hope you like my choice of music. We have choice of music. Those of you who've been before, I have a normally eclectic taste in music. The events team at Wellards have insisted this year that we need some more sensible, younger kind of music for the audience that we have. So you will have noticed that the music to kick off today was the X Factor. Hands up those who are X Factor fans. Sad, isn't it, really? And I was told I need to do a Dermot O'Leary twirl, but I don't know how to do that. And those of you who are a bit longer in the tooth will remember that that music was chosen by several devil-worshipping, thingy movies in the 70s and 80s. And I thought, how can I get a link to the X Factor music to our conference? Well, of course, the devil is in the detail. Thank you very much. And I worked in for Pharma. I should say hello, but I do apologize. I didn't introduce myself. My name's Alan Jones. I'm an independent health policy analyst. It's been my pleasure. I've rehearsed this. You can tell I'm talking very quickly. It's been my pleasure to program today, and I'll also co-chair it with Professor Paul Truman, who's sat there, who I'll introduce in a minute. So the devil is in the detail. I worked in pharma for 20 years. I can't remember a period of more profound change to your client base. Just when you had payers sorted out, bugger, they start reorganizing themselves again, and the acronyms start to change, PCTs to CCGs. Can you keep up? Well, what we hope today is fill in the detail of that devil. We've got a very high-profile cast of players for you. Please grill them, interrogate them. They've all been briefed to think about the implications for pharmaceutical companies. I don't envy you working in pharma at the moment. Not only do you have a very turbulent environment, but your head office keeps reorganizing you. It's very challenging for people coming in from the outside trying to keep their business going too. We have a fantastic list of exhibitors. We have some seats at the front, guys, if you'd like to come round. It's not your fault you're late. I won't pick on you, honestly. If you'd like to come down to the front, please, rather than sit at the back. If you sit on the seats at the back or the steps, the Royal College will throw us all out, so we don't want that to happen. So these are very turbulent times, and we hope at the end of the day you get some inclination of what these reforms mean for you now, but more importantly, in thinking about programming today, what they mean for you and all the people working in both the field and head office as they prepare their plans for 2012, 2013, as allegedly we come out of transition, or the NHS comes out of transition. I was just going to say we have a very good group of exhibitors. Please visit them during the course of the day. We've invited several NHS stands along. Both PCC have information on working with pharma. Joint working is still sexy mantra, I think, this week in the pharma. I haven't read anything to think me otherwise. And the association that represents finance managers in the NHS also has something on working with pharma. So that's enough from me. You'll hear more excellent music during the course of the day, more intelligent observations from this co-chair during the course of the day. But let me introduce my other co-chair, Professor Paul Truman. Paul and I go back 20-odd years, Paul, I think. We were both Glaxoids. Any Glaxoids here? Any ex-Glaxoids here? Yeah, we get about, don't we? I was then a founder member of, I think, what's the first NHS team in the industry working with FHSAs, those of you remember those organizations. Paul was one of those poor health economists. He wasn't poor, he's very well paid, I remember, who were obliged to try and find a drug cost-effective after the price had already been set. Quite a challenge in those days, I think. So Paul's since had a very distinguished career. All the speakers' bios are in the pack, so I won't introduce speakers any more detail. So If I could hand over to you, Paul, to introduce our first speaker. Thank you very much.
Thanks, Simon, and good morning, everyone. Nice to see such a full house, which is a great sign. So we're looking forward to a really active and engaged day today. We're really encouraging you to get engaged, make the best of this opportunity to engage with stakeholders, individuals who perhaps you don't often engage with traditionally in your day jobs. So please do make the most of this today. We are in a very interesting time for the NHS. We live in interesting times. It's probably a phrase which we overuse and a phrase we could use about the NHS at any time over the last 60 years, I suspect. But the scale of change which we're going through at the moment is pretty much unprecedented. We're looking at significantly changing how we fund healthcare. We're looking at significantly changing how we organise healthcare. We're looking at cutting management out of the system. We're looking at changing how we manage public health, all against a backdrop of efficiency savings, which, if you want to look at it another way, could arguably be cuts. So it's an incredibly challenging time that we face. And from a farmer perspective, knowing that many of you are from the pharma industry, there's some real interesting challenges ahead in terms of what the future role of health technology assessment is, value-based pricing, which we hope will offer some reward for innovative drugs. But that begs the question of what do we do for drugs that are non-innovative, or all the portfolio drugs as well. So some really challenging times ahead. I would urge you today to make the best of this opportunity to explore some of these issues with our speakers. We do have a great panel of speakers today who could throw insight onto some of these issues. Just on an administrative note, I will please say, can you please switch off mobile phones, Blackberries, iPads, iPhones, whatever kind of device you're handling today. I am told that people are not getting reception in here, which is a great thing, so hopefully we don't need to switch them off, but please switch them off if you possibly can, so that the meeting can run as seamlessly as possible. So without further ado, I'm going to press on and make the best of our first speaker's time. Our first speaker is someone who I'm sure many of you are familiar with, Professor Chris Ham. Chris is Chief Executive of the King's Fund and has been since 2010. He's also been Professor of Health Policy and Management at the University of Birmingham since 1992. Many of you will be aware he was Director of the Strategy Unit at the Department of Health in the early part of the last decade. And generally, I think Chris is a leading commentator and influencer in the arena of healthcare. Many of you will know he's often ranked in the top 20 opinion formers in the HSJ League table, so someone who is very well positioned to try and throw some insights into the challenges that are facing the NHS today. Chris, unfortunately, can't stay with us the whole day, so after his presentation, we do have time for a few questions, so please bear that in mind and try to think of any questions as we go through this. Chris, over to you.
Yeah, thanks, Paul. Well, thank you very much, Paul, for the introduction. Good morning. I'm pleased to be here and to talk about this very broad topic, exiting the transition. What I'm going to do, my interpretation of this is twofold. In the first part, I want to say a little about the financial and service challenges facing the NHS, the QUIP agenda for short. In the second part, I want to go on to talk about the government's plans for reform, the legislation, where we've got to, what it might mean. And then right at the end, I want to try and connect those two elements. Will the reforms help or hinder in the delivery of the QUIP challenge and enable the health service to do more with the same? That's the phrase we're using at the King's Fund, the same amount of resource going forward, but a need to use that ever more efficiently. And that's the overview of what I plan to say. As Paul said, I'll keep my comments to about 30 minutes, so I hope that'll leave some time for questions and discussion. Starting with the time series, the graph that shows the trends there have been in NHS spending going back to the early 1950s. And you'll see, if I add this in, the historic trend was the health service budget was growing, has grown by around about 4% each year after allowing for inflation. But more recently, we've seen a rapid growth. The priority that the previous government, the Blair and Brown governments, gave to the NHS at a time when public spending as a whole was increasing and health spending increasing, particularly during that period. A decade of investment, if you will, a decade of reform. And that's laid the foundations for many of the changes and the improvements there have been in the NHS. There's a longer story to tell here, but the headlines are these for me. Increased spending has delivered results. We've seen major improvements in the performance of the NHS, particularly around access to care, cutting waiting lists, and especially cutting waiting times for treatment. A&E is one example, the time people wait for outpatient appointments for their operations, cancer waits, many other examples. And much of the extra investment has gone into improving access to care, but not all of it. We've also seen big investment in the clinical priority areas, cancer and cardiac care, narrowing the gap, if you will, between this country and other countries, what they deliver in terms of best practice performance. Much of the spending, though, has also gone into pay. The new contracts, GPs have benefited, consultants have. Agenda for Change has meant big pay increases for other groups of staff as well. And what's been the benefit? Well, if you look at the evidence, probably not a huge amount. There has been some benefits. If you look at the impact on GPs, QoF and the attainment of quality targets in primary care, building on previous trends, then clearly there has been benefit for patients, but in other areas, much more questionable. The Commonwealth Fund is a New York-based foundation, a little like the King's Fund. It carries out annual surveys to compare different countries' healthcare systems. I don't know if you're familiar with their work. They have a very informative website which summarises a lot of that. And their surveys show very clearly that the UK's performance across a range of metrics in healthcare has improved relative to the other countries within its survey envelope. And today, later on today, they will be publishing the results of the survey they've done this year, looking at the experience of sicker adults in using healthcare services with a particular focus on primary care and continuity of care. I saw the results of that presented a couple of months ago. It's embargoed, but I think on this occasion it doesn't greatly matter to say it will show the UK in a very positive light this year. So despite all the stories we hear, well-founded stories about problems of the quality of care, particularly for older people in the NHS, other evidence paints a much more positive and optimistic picture, and the survey to be published today will reinforce that. But we are moving beyond what have been 7 years of feast into perhaps 7 years of famine, if I can be a bit biblical about this. That the long-term increases have been the ones I've showed you, 4% every year in real terms, 7% more recently, but for all the reasons that we're familiar with, that will not continue. The new government spending review said very clearly for the next 4 years, the budget for the NHS in England will increase in cash terms, but it will not increase in real terms, apart from a very, very tiny percentage increase. And even that depends on the assumptions you make about inflation. So relative to other public services, the NHS has done really, really well. Let's be clear about this. But compared with where we've come from over the last decade, or indeed over the last 50, 60 years, it will feel very, very tight. We are now in the first of 4 years of unprecedented financial squeeze for the NHS, and it's beginning to hurt, and I'll come on to talk about that. Sir David Nicholson, Chief Executive of the NHS, now the new NHS Commissioning Board, has said, as you'll be aware, the health service therefore needs to become much more efficient, to find between 15 and 20 billion pounds to deal with increasing demands. Now let me just pause on this. When he talks about 15 to 20 billion pounds of efficiency savings, he is not talking about cuts. The budget for the NHS in England will increase in cash terms over the next 4 years. It will not reduce over the next 4 years. What he's getting at here is if the health service is going to rise to the challenge of an aging population, if it's going to find the money to fund new expensive cancer drugs or other technologies, if it's going to do better in meeting the needs of frail older people who often don't get the quality of care they have a right to expect, then there will be a need to free up resources from within the existing financial envelope and to reallocate that money in those other directions. So not a cut, the budget will increase in cash terms, but the efficiency savings will need to be made if the health service is to fund new drugs, new technologies, improvements in patient care that otherwise will not be made. That's what the 15 to 20 billion pounds refers to. So the familiar image, for colleagues working in the NHS, it does feel very much like